started. And just want to make sure everybody online can hear us okay. If you just give us an emoji or something. Want to make sure that we're, yep. All right, cool. Very good. Very good. All right. So I'm not sure which lunch and learn this is, but it's one of them. Fifth, sixth, fifth.
Close enough.
Close enough. That's right. So, okay, just a couple quick announcements before we get going. So we just started the Translational Medicine Journal Club. We had the organizational meeting last week. This is Ben French. Ben, raising your hand. So Ben's a PhD student in our lab. He's helping to organize this with another PhD student, Delani Falil. And Sarah, I'm going to butcher your last name, Zenakili. So is Sarah here? No. Anyhow, so they're organized. I think we just had another quick meeting today about we'll be sending out a web form to ask people for. Can I just get your attention? Thank you. So they'll be sending out a web form to ask people if they're interested in participating and volunteering for different activities, et cetera. They're going to organize it with GroupMe, which apparently is an app that you can put on your phone. I won't tell you that I don't know how to use it.
You don't have GroupMe?
I don't have GroupMe, but I will. It's open to all of our students. The meetings are Fridays at noon. The next one I think is in January. So we'll be organizing before that. So look out for those. But again, since they're going to be organizing it through GroupMe, just make sure that you contact us or Ben or Sarah or Delani to just get plugged into that. So anyhow, that is that. Our next lunch and learn will be with Margaret Hoogland, who's also online. Thank you for joining us. And she's going to give a workshop on sort of all the things library science related, so impact factors, citations, journal selection, and then most importantly citation management, because I know a lot of people struggle with that. What's the best one to use? We've even had issues with I don't know, people use EndNote or whatever, but we just put in a grant and that was a mess with EndNote, and so there's different software to use, and she'll go over that because that's really helpful.
I did the references. What are you trying to say?
I push it off on Steve because I'm too dumb. So that'll be Wednesday, January 18th. So that's our next lunch and learn. And then last but not least is our office hours. So we're doing this to give people an opportunity, if you don't have time after one of these or don't see us in the hall or whatever, just to make ourselves available. So this will be up in, this will be December 16th, which is this Friday, 4 to 5 p.m. Our lab is right upstairs. We share a lab up in that corner of HEB. It's 205. You're welcome to come there in to see us, or we'll also have a WebEx pulled up for folks who are on.
And
online.
I think that's on the department calendar. Right?
Yep.
I put that on there.
Yeah, so that'll be on the department calendar. And it already is. And all these things will be on the department calendar. So without further ado, we want to introduce William Barnett, who is our Quality Improvement and Patient Safety Education Officer. And this is going to be, I'm excited for this because it's really high yield. What we asked Bill if he would do is, in addition to kind of giving the overview of how things work in terms of quality improvement, talk about specific opportunities that you could jump into as medical students to get involved in research. So he's going to overview about half dozen or so projects that you can get involved in. So anyhow, we're very lucky to have him here. He's well, I think he'll tell us he spends a lot of his time over on the ProMedica campus, but is here today. But anyhow, so without further ado, Bill, thank you very much for joining us, and I'll pass it over. Yep, there we go.
Okay, so yes, I'm William Barnett. My primary function is working with our medical residents. We have the largest residency here at University of Toledo. We have about 60 medical residents. And so as part of their ACGME guidelines, as they have to participate in quality improvement projects, they have to know about quality improvement, they have to have a working understanding. And so that's kind of what I do is to facilitate, usually about, well, when I was here at UTMC, we ran about 12 projects a year. It's about half that with the affiliation, but still 6 to 8. And so, where were my objectives? Okay, yeah, so the objectives for this discussion here, so there's gonna be like some learning stuff here, like three or four slides on discussing the conceptual framework used to evaluate the quality of healthcare. So yeah, that's my teaching point here. And then we'll review some of the previous research that I did here. And I'm really going to focus on what I did with medical students or where medical students were involved, rather than like everything I've done. We'll talk a little bit about the current research opportunities in the Department of Medicine. And then probably what you're all here for is like, how can I be involved? What would my role be? So we'll talk a little bit about how medical students have been in these projects and how they can get in them now. So evaluating healthcare. So probably not many of you know who this guy is, but he's Avidus Donabedian. And he was at University of Michigan for most of his career. I believe he was Armenian born, lived in Palestine, came over here. And this is really the father of evaluating healthcare or healthcare outcomes. This is the guy that kind of came up with it. And one of his quotes is, ultimately, the secret of quality is love. If you have love, you can then work backward to monitor and improve the system. This guy was a poet as well. He had tons of poems, never published any of them, but I guess he was a really great poet. But like I said, University of Michigan is where he spent most of his time. But his kind of claim to fame here is the Donabedian model. And it's really simple to understand. And you're going to look at 3 areas, and it's really the structures of care. So how is healthcare delivered? What is the type of setting it's delivered in? And then he said, okay, well, the processes of care, how is care delivered and how is care coordinated? And this leads to health outcomes, whether good or bad is kind of what he said. And so when we talk about structures of care, what we're really talking about is the conditions under which healthcare is delivered. So we're talking about, do we have the proper equipment and supplies? Do we have the proper levels of human resources as far as do we have the right staffing levels? And that's just not physician, but also could be nurses, it could be therapists, it could be social workers. So the whole gamut of the healthcare delivery system and everybody's role in that. Are they well qualified? How well are they trained? What are they trained in? And so this can go on and on. What about your hospital administration? How, do they kind of get into quality and they really look at their measurements and their metrics, and do they take an active role in that? Kind of this idea of top-down leadership. What about the environment itself, where it's delivered? The culture of safety, and the culture of safety being, do we feel safe if we report things that we see are wrong in the hospital? How safe do we feel doing that? Because there is sometimes a risk associated with that. A perception of that is that if I turn somebody in because they did something wrong, or I see something odd in the hospital, that it's going to come back on this person and hurt them, professionally, or it's going to come back on me for reporting it. So it's that idea of culture of safety. How safe is your system? What about the availability of technology? So it's just not the equipment and supplies. Do we have the right technology? Are we at the cutting edge? So all this kind of plays into this idea of good and bad outcomes. So the processes of care. So if we're going to define a process, we're going to talk about a series or a sequence through which inputs are transformed into outputs. Most of you should be able to understand what a process is and kind of how it works. But you take something, suppliers, somebody gives you something, you carry it out through a process, you have process owners, those are the people that perform the activities, and then there's an output, there's something delivered to a customer. So, a process we could talk about commonly is, okay, let's talk about the discharge process. There are steps to discharge a patient once they're in the hospital, and you follow these steps. You have a patient goes through it, and at the end, that they're done. or even a diagnosis. You all know that there's different steps in that, procedures that you could be done on this patient to get to a final diagnosis, being that outlet. So processes of care. So he said that the health outcome, it refers to the results of care if it's adverse or beneficial. So your process, your environment that you deliver care in, all combines to an outcome, good or bad. And so really the areas that I looked at were clinical. So we know mortality, okay, we know, do you have a high mortality rate in the hospital? We know what type of complications you're having. Do you have, high infection rate, central line infections or surgical site infection? What about adverse events that aren't related to that? What about patients falling in the hospital and breaking a hip or some other, body part, and now they're in longer than they should have been, okay? So these are kind of the clinical things. What about the functional things? Ability to perform your activities of daily living. That could be a result of the structure in the process. What about patient satisfaction? How we perceive our healthcare as being delivered to us as patients. The cost savings, the financial implications, and the utilization. So ideas of productivity and length of stay. Length of stay being a very big area to look at. And so these are kind of outcomes that I really look at when I'm coming up with the project. Or, we see something in the hospital and we want to try to improve it. So just taking the Donna Beatty model, these simple steps, we're going to go through some previous research at UTMC, and I'll probably ask you, what is, a little bit about like what's the structure that we're looking at, what kind of process am I looking at? What are the outcomes that I was looking at with these projects? And just feel free, to chime in. But first, let's talk about the structure of how we do quality improvement in patient safety and residency. So this is kind of an old kind of graphic, but it still holds well. This is actually probably from an old bridge course, and probably the last time I did it was probably here in this room, gave this lecture on residency and quality improvement. But anyway, so what we have is we have a guidance team. So we have our residency committees, we have our program director, Dr. Vasali. We have all our associate program directors, our chief residents, and really now our associate teams. We have 6 of them now, because really we're between for the most part, two different institutions, primarily at Toledo Hospital. And then we have my role here as the quality and patient safety expert here in the College of Medicine. And this really feeds our QI teams. And so the QI teams are really simple. Not so much a faculty member anymore. We have some projects where faculty members are part of them. We used to have every faculty member. If we were doing cardiology, we'd have somebody from cardiology. GI, we'd have some GI. But with this academic affiliation, it's not the same as it was here, and so it's sometimes really difficult to get a faculty member. We usually have team leaders, and that's usually a senior, typically the 3rd year PGY3 resident is usually the leader, sometimes the 2nd year. And then, we have interns on these teams, and then we have medical students. There was a time when I had about 30 medical students working on, a dozen different projects. And this thing over here, this is the Donavidian model. This is quality improvement methodology. It's just all the dry stuff that you guys don't want to hear, all the technical stuff about quality improvement that'll put you to sleep. But that is what drives our quality improvement teams. So that's where I kind of facilitate, the quality improvement science portion of it. And then, we're working with the leaders at the front line, so our physicians, our nursing directors, and then of course our frontline workers. We have residents, medical students, again, nurses, social workers, everybody that works in healthcare. It's kind of part of this chain that we do because we need them. Sometimes there's projects that are, seem like they're physician driven, but it might be we're looking at something that's on the level of a social worker, like transitions of care between UT and say a nursing home or a SNF, skilled nursing facility. So sometimes we need to have other ancillary people involved in these projects. because they're the process owners. They're the ones that do this day in and day out. They're responsible for that. Anyway, so I'm going to go through just a few projects again. This one is this autopsy learning module, and we know that autopsy has been recognized as an important tool for learning and quality improvement in clinical practice. And so what we did with this project is, before we wanted to really kind of come up with this learning module for ICU staff, is we really wanted to see how well we are at clinical cause of death and what the final diagnosis is. And what we found out is that when we looked at the treating clinician's cause of death list and the cause of death listed by the pathologist after the autopsy, we use capital coefficients to do this. I don't want to get into the statistics of it, but we found that there wasn't good agreement in areas like MI. So myocardial infarction, sometimes, what they thought was a clinical cause of death from the pathologist didn't mesh up with what the physician said. Pulmonary embolism was another thing off the top of my head that I can think of. So there is some area where we can improve this. And so really we found that there was an unmet need for training in our residents about the autopsy process. It's not that they need to know about what a pathologist does, but what we find is that residents really don't have the communication skills sometimes to be able to secure an autopsy. And so they don't really feel comfortable doing that. And so that was kind of part of this autopsy learning module that we kind of developed here. And really the goal was to implement measures to improve autopsy rates. So if anybody wants to chime up, so what process are we really looking at here? What's the process that we're trying to improve? Anybody? It's kind of out there already if you need to look at the notes. So we're going to try to improve that resident to patient process on improving their communication. What kind of outcome what's the outcome that we're looking at? What's the measure that we're trying to improve? That outcome, good or bad? That's exactly what it is. So back in the 60s, autopsies were done about 40% of the time. So a patient died in the hospital, 40% of the time there was an autopsy. Anyone want to guess what the autopsy rate here at this hospital was before COVID? Because I can tell you it's not 40%. Wild guess? So I'm getting small. It's really small. It's like 9.5% is what we came up with. And really, once COVID hit, it's like it was non-existent. No autopsies done at all. And so this is opportunity to learn from these. And so again, we're looking at process, just to kind of show you a graphic, talk about process. We look at the medical ICU rotation. So your ICU rotation begins, you get online training, resident, begins the rotation. A patient dies, yes.
So if gratification, what are the outside forces care about increase?
Well, and it's just not the correct diagnosis. It's the fact that you want to improve the autopsy rate because they just don't get done. There's this kind of, I don't want to say fear, but there's this, we have technology and we assume that we have all this medical technology that we can get the diagnosis right. And so there really isn't anything beyond that. Why we don't need the autopsy. Why should we even do an autopsy? We got it right because we have the technology. The other piece being, like I said about residents not having that ability to secure. Sometimes there's misunderstandings about autopsies. So that was kind of part of this whole thing. But really the idea that came from this, and you'll see it here on the right, is there's not a lot of tools to gauge quality improvement competency in residency. And so, you can't just do something and be competent. There's not a direct way to measure that. What you get is all these different things, quality improvement projects, attending didactic lessons. And then maybe if the self-reflection is another piece to add to it, to where now the autopsy has been done, and now you complete a self-reflection. So the goal of this thing was to have the resident on that ICU rotation do a self-reflection. Now that they know what the cause of death was, how would they have done things differently? And so now they can kind of do a little form, write a paragraph about it, and then this can go to the resident director. Resident director can check it off and say, this person gets quality improvement, they participate in this, and this is just another tool to gauge your competency. And so this is all that was just to kind of come up with a way to improve, to not only improve competency and quality improvement, but also to improve the autopsy rates in the hospital. And so this was done by myself and Dr. Gohara and one of the residents, and of course, Dr. Saleh, but Christian Coletta, he did the whole literature review for this paper. This was published a few years ago. So again, just another role that a medical student had in this. Without getting too much into ventilator-associated events, one of the projects this is really my area that I work on. It's quality measures, and ventilator-associated events are objective measures by the CDC. So these get published every month to the Centers for Disease Control. And they're kind of really like surrogate markers for not only following. We used to follow ventilator-associated pneumonia. We don't really do that anymore because it's too subjective, because you can get a bunch of physicians in a room, give them all the information about this patient, and 8 out of 10 of them will say it's a ventilator-associated event or a pneumonia, and 2 of them won't. And so it's too subjective. They needed concrete measures. So anyways, what we did here was we really wanted to look at what the hospital had done was, without getting too technical into it, really what they did is you start patients on a higher ventilator setting, hopefully that you can turn it down, because if you turn it up to a certain point over a certain period of time, that triggers this whole VAE process, this ventilator-associated events. And so this was kind of the hospital's strategy to try to reduce these things. And so what we did was, we didn't look at the usual way things are reported, how many events per 1,000 ventilator days. We really looked at it from more of a mathematical probability aspect, is we could calculate what's the probability of an event happening in a day, and was it expected or unexpected. And if you really are interested in the mathematics behind that, you can, of course, look at the paper. But really what we found out is that the strategy that the hospital was using really didn't do anything about reducing our VAEs. And so, we published this a little more recently. This was last year, but again, these were residents on here. And then Zach here, he was a medical student. He did this his 3rd and 4th year. He worked on some projects with me. He's now an intern in our program. So he wanted to do critical care. So this is kind of what he wanted to do. So what was the outcome that I was looking at here? What was I reporting here? What was the outcome, good or bad, that I was interested in looking at? What measure? Second paragraph, first part. Direct you. Yes. Yeah, so I was looking at the ventilator associated events per 1,000 ventilator days is what I reported, but I didn't look at it that way. I looked at it in a different mathematical way. So that's the outcome that they're really looking at. It's something quantifiable like that. And so the process, again, is just a process of a patient on the ventilator and their whole experience, basically, to say, for lack of better words, their whole experience on the ventilator. And that was the process that we're really looking at. Again, if you're interested in the mathematics behind it, you can look at it. Again, these are just conference papers that we've done on ventilator-associated events. looking at, does endotracheal tube size matter? Is there gender differences in how big your endotracheal tube is? And this is actually, he's adjunct, he's actually now a fellow here. He graduated and then he went to residency and he came back here to be a GI fellow. Amala Amada, she was a student here. She went to residency here and she was the chief resident a couple of years ago. Christopher, Kevin, I mean, these are all medical students that were involved in these projects. Same thing here, Jessica and Stella. Central venous pressure is correlated to these things. So, these are just conference papers that we do and that the medical students are involved in. Same thing, ATS, we do these conferences, the same thing here, correlation through different modes of mechanical ventilation and VAEs. This has been a treasure trove of information because nobody really looks at these VAEs. Most institutions don't. So a little more recently, again, I think Chad's a second year now. Zach, again, I talked about him, James Williams. I think he's second year now, medical student. He's actually my MPH intern. His MPH here, and we did a few papers. So here's, again, just looking at ICU status and doing machine learning things. Can we predict when a patient is going to need to be escalated to ICU care, COVID-19 patients? So again, just more conference papers. This was actually ID week and published in the annual conference journal. Anyway, so hand hygiene. There's sometimes projects don't get to be in conferences or we don't publish them, but they're still really important. And this is actually one of my more interesting projects. We were approached by a local biomed company here. They wanted to do proof of concept. They actually approached Dr. Duggan, one of the ID docs, and then she said, hey, would you be interested in this? And really, they didn't have a prototype, but what they had was an idea. And so I basically translated what they would have built into, looking at this idea that these community examination clubs, most of you have seen these, they sit up on the floors, people put their hands into them without, sometimes without washing it, and they pull gloves out and put them on. So if there was technology that was able to have a clinician be able to don a pair of gloves, a sterile pair of gloves, rather than dipping into that community examination gloves, would this be better than what's done all the time? And so this was the question, would examination gloves that have been consistently done on a clinician carry less microorganisms? And so we did this in the sim lab. I had nice pictures of one of the interns from the MPH program that did this, but I can't find them anymore. And basically, I was the technology. So I stood around for 2 hours like this with my sterile gloves on because I was the machine that was assisting all the people on this project. And really, these are actual plates from the project. The funny thing about this is Dr. Duggan was like in Fulton County. She forgot all about this to open her lab up. And so I'm walking around like the health block building with like a bunch of auger plates, and I'm like, I have nowhere to put these. Like, I have nowhere to incubate these. And so I ran around, talked to a few people, and finally it was Dr. Altoric's lab here that said that, yeah, you can put them in here. So yeah. But again, just another project that we have medical students on. Again, other resident-driven QI projects. We have a modified early warning system here in the hospital that looks at deteriorating patients. This is an idea, can we predict code blues? And so this was the project that I had many medical students on. MedRec, so medication reconciliation, transition of care, fall prevention has been the big one. That anybody ever catches my first lecture in our quality improvement lecture series, it's always about fall prevention. And STEMI guidelines, so non-STEMI guidelines in the ED, PPI overuse, so that's protonics overuse. Again, we just get into a lot of different areas. So what are we doing now? Besides listening to me. So what about the current project? So one of the things we're doing right now, and these are really, we're trying to get away from UT and trying to do more things at TTH, because that's really the learning environments for all our trainees. And so we're really trying to work with, so this is kind of a joint project between TTH and the College of Medicine residency. So this is fentanyl use in the ICU. So this is a project ongoing, and this is probably one of the projects we probably need a lot of people. So we hypothesize that the use of high dose fentanyl. So we're talking about in the ICU, sometimes they use a lot at TTH for whatever reason. Now, we don't do that here at UT. TTH does. And really, I don't want to say it's improper, but it's really not the way to use fentanyl. They kind of use it a little incorrectly. But anyways, what they're really concerned about is hospital length of stay. Besides just the fact that you're using this high dose, and the idea is that it kind of comes from this idea of chest wall rigidity, where patients have this issue and they stay longer on the vent. And so this is really what we're looking at. Plus, nobody really knows about this high dose fentanyl. Some of these patients are in there for two to 3 weeks. And some of them probably have never been on any fentanyl or any opioid at all. Is there a potential that these patients may have long-term dependence or issues with this? We don't know. And so that's one of the areas we're looking at is this. And we have all the data for the most part. It's something like 8,000 patients. So that's kind of a big project for a small team of residents to work on. Transitions of care, patient handoffs. I read this here, programs in the partnership with the sponsoring institutions. So really, this is actually right out of ACGME. This is the guidelines for residency programs. We really need to be monitoring, having a structured handoff process. And so everyone's familiar with transition of care, patient handoffs. You guys should have got this at least somewhere along medical school. Handing the patient off to a different service, patient going from inpatient to getting transferred to another institution. Those are all transition of care. And so really, here comes the competency part. Residents need to be competent in communicating with team members in this handover process. And so one thing we don't have is a really structured handoff method. There's some things out there called IPASS and SBAR. And so really what we really want to do with this is really look at if we develop this for the residents, test it on our IMS. And for you that don't know, that's an internal medicine service. That's all the medical residents. And so that's a project. New ground here. We really haven't had anything in this area. Outpatient colonoscopy screening. This is actually a really interesting one. We've done work on outpatient colonoscopy, residents understanding, improving their understanding when they talk to patients. But this is a little bit different here. And what we found out is that, when we order a colonoscopy, so when one of the residents in their general internal medicine, one of our clinics, either Falls owner or CC, South Toledo intern is the other clinic. We really don't know what happens with that. We assume that the patient actually goes and gets this done. And sometimes, as the residents report, is that the next visit, did you get your colonoscopy done? Oh, I forgot, or I didn't know about it, or whatnot. So that just you have nothing to discuss. If that was your next appointment. And so really we're going to look at all the colonoscopies from last year ordered by both. How many were successfully completed, and we're really focusing on patients, of course, 45 and older, because now some of the guidelines have changed. And is there any way we can intervene in this process? Actually, we spoke with the schedulers and we learned there's two different processes going on. There's one process if you order it at this clinic, and there's another process if you order it at this other clinic. And so trying to improve these two different processes and come up with something where we can get a little more feedback on screenings we've done. Social worker and IMS. So there's one IMS team. We actually have 4 of them, but there's one that gets in an embedded social worker. And these are really helpful, you know, in healthcare delivery, to have a social worker involved, just like it is having a pharmacist involved on your internal medicine team. And so really, we want to look kind of retrospectively at the social worker and what their impact is on the length of stay. Again, length of stay, you know, bed turnover, all that, that's money for institutions. Get patients out and make sure they're well when they get out, or better when they get out. We really want to try to improve that length of stay. So that's one of the projects that we're the management of acute on chronic liver failure. So this is actually, I pulled this from the IRB, actually Dr. Soderman and working on this one. So this is at TTH targeting acute on chronic liver failure. And really what they're trying to do is to improve patient mortality and morbidity. So again, these are the health outcomes that we're interested in improving. And so really what they want to do is create a dot phrase. Anyone familiar with this term, dot phrase? Okay, so this is when you guys start going into the EMR and start actually doing notes. One of the dot phrase is basically just a short piece of pre-done text so that you could have a bunch of information there and you just basically click it. And so this is what Dr. Soderman and his team is really looking at, is if they had a dot phrase that would help even residents at the first year understand, you know, what tests do I run, what labs do I run for this acute on chronic liver failure, you know, what should I be doing to help improve that diagnosis. So it's not only improving the diagnosis, but it also helps in training. And so they're going to look, of course, at mortality, length of stay. Again, that's dollars. Again, timeliness if they need a paracentesis, and of course, a readmission rate, because again, that's one of those quality measures that hospitals get, for lack of better words, they get dinged on if they have too high of readmission rates. Because the idea being that is being counted before when they're in the hospital, you should have done everything you could to improve that patient. No reason they should be coming back in 30 days. PCP discharge, this has been a struggle because, you know, we have an academic affiliation, but, you know, at the same time, you know, we're still 2 competing institutions. And so sometimes those politics get involved here, but what we're trying to do is there's patients that come into TTH, into Toledo Hospital, and they don't have a PCP. Now, ideally, what should happen is, of course, they should be seen within 3 days or, you know, a week in our clinic at FL Zone, which is right across the street. And so that process, for whatever reason, isn't as easy as you would think it would be. Some of them get seen at other places other than UT. So we've been looking at several ways to improve this transition to Toledo Hospital. FL Zone is actually where my office is. So I spend a lot of time trying to figure. Adapting Vital Talk to residents and fellows. So this project is kind of probably, I don't want to say run its course, but this one got started early. So this is Dr. Collier, who is one of our end-of-life physicians, palliative care. And so Vital Talk, again, I just took this right from the website. It's a training organization for clinicians to advance their communication skills. And so, again, right from their website, just as no doctor is born knowing how to handle a scalpel, the same is true of how to communicate effectively with serious ill patients and their families. And so this has been used for attendees. Has it been used for trainees? Has it been used for residents and fellows? And so what they started doing, Dr. Collier and his team of residents, is offer these Vital Talk sessions to their trainees, to our trainees. So we've done it twice. We're going to do it at least once more in March. And so created a survey to kind of evaluate that. So like I said, this project is pretty much, probably doesn't need any money on it. IMS consulting services. I don't have much to say with this one is because the resident that's in charge of this one was the last person to tell me what the heck he was doing. And so that's sometimes what happens in residency. Sometimes it's hard to get a hold of the team leaders because they're on different services or they're on night flow. But this might be something worth looking at. And so we really don't know about IMS consults. You know, do we consult more services than other? Is there over consultation? You know, or are these consults being ordered too close to discharge? So you can imagine it. You have a patient that's ready to go the next day, and then you're like, oh, I'm really worried about something. I really need to get the specialist involved in it. What does that do to them getting discharged? More than likely, maybe they're there for another day, you know, and that translates again into money. Side projects, you know, throughout the academic year, you know, people approach me for different projects from sometimes different services. Neurology sometimes contacts me. But then one of the projects that kind of came up, and this was Dr. Asali's idea, talking with the keynote speaker for our annual symposium. You know, what about lung cancer and lung size? No one's actually ever looked at that. You know, people that have lung cancer and have different lung capacity. So that's just a project that just kind of comes up out of the blue. And then my area, again, machine learning models. I'm always looking at ways to come up with predictive modeling on different areas. COVID, as you can see, ventilator-associated events. And again, there's always other departments collaborating. So sometimes it's like they have an idea and they're like, can you get some people involved in this? Get more medical students on it. Can you get some bodies in there to kind of help with this? And so those come up throughout the year. So as you've sat through this thing here for the last half hour, whatever, you're probably understanding, you know, what's my role in this? You know, how can I get involved? You know, what would I be doing? And so how do you fit into this? So you're a frontline worker, or not you think you are or not. You see how healthcare is delivered. Some of you are just learning that, and some of you may be already involved in it. And so you see how it's delivered. And so sometimes you see things, and sometimes you can come up with ways to improve that. And so I'm always interested in listening to any of you on an idea, and we can try to help, you know, flesh that out. But really, the majority of medical students in these projects, they really receive practical experience in one of these residence-driven projects. Really, what you get out of it is you really get instruction in healthcare system science. Whether or not you really realize that is the way healthcare has been delivered since the beginning of time, and even recently, it's not the way we're going to do it anymore. There's more, you know, quality improvement measures that hospitals and physicians are under more scrutiny on how you deliver care and what are your outcomes. And so this is just a system you're going to have to work at, and I don't think it's not going to go away. And so really kind of just getting an understanding of how you improve a system, you know, is beneficial to you. Some exposure to biostatistics. I do all the biostats for every paper I've published and every conference abstract that I've done. So for you that are interested in that aspect of it, I mean, I'd be more than happy to show you my thought process and how you actually do all these and how to interpret results. Depending on how much time you want to commit on a project, you can be involved in different ways. Most of the time it's collecting data. That's one of the biggest areas, but like I said, you know, sometimes participating in literature review, depending on what the subject is, it's going out there and actually learning a little bit more about what we're talking about and actually coming up with a paragraph to put in a manuscript or helping with the abstract. Creating tangible items. So tangible items could be something like, you know, I had a medical student in the transition to the facilities to ECFs and nursing homes. And we were trying to come up with a basic checklist because this doesn't get done when the patient is discharged to a facility. is what are the key elements in there? There's about 15. Things like, okay, what was your, your diet? What was your last, 3 progress notes? Or, there's a whole checklist that you should have done that should go with the patient. And he actually wrote the whole thing. He did a nice little form, and he did the whole form himself. So that's what I mean by creating tangible items for it. And then helping to write with the draft of the manuscript, just understanding that process. That is something that medical students are involved with on these projects. And so really some of you will may be interested in one project. Some of you may want to do more than one. It's really up to your time commitment. And like I said, most of the time it's usually 3rd and 4th years that have been involved in these. But most of these projects are longitudinal. And so as you can see with some of the previous projects is that these go for multiple years. And so if you're a 3rd or 4th year, we may still be working on the same thing. If you decide, if you're going to come over to our residency program, if you get accepted there, you may be working on the same project for your whole residency there. And so that's really what we want to have is this longitudinal idea. Like I had said, most of these generate conference abstracts. Some go on to publication. And then the last thing here is every resident project that we do gets presented at our annual symposium. So this is aside from the one that the Department of Medicine does. This is one that's specific to residency. And so really what we do is we compete with all the different projects. The top 3 get prizes at the end. So it's one way to kind of put on your CV here, I was involved in this project and I won this or I placed in this symposium. So that's really all I have for you. Questions?
We have time for a couple of questions. I know there's some people waiting to get in the room at 1, so we'll just as you're thinking about things. So this is just absolutely fantastic for medical students because I know many medical students, you're interested in a wide breadth of things, and Phil presented today ranges from machine learning to GI related to infectious disease related to cardiac related to, it spans the gamut. You don't have to do, if you're interested in a residency in GI, you don't necessarily have to do a bench experiment to get that experience. One of these projects would be perfect and allows you to have longitudinal experience. So, and then also in addition to the presentation opportunities, there's even national presentation opportunities specifically for these quality improvement projects. So not only would you have an opportunity to present locally, you'd also have an opportunity to present nationally at those meetings. So again, I thank you so much because it's yeah, not often that you get one person who has access and opportunities in so many different areas for you. Any questions? And then also to open it up online, if there's any questions online. I can't see the chat because I don't have my glasses, but you can feel free to unmute and ask a question from online as well. Oh, here, let me.
Yeah, so you were asking about reaching out. So yeah, for those that are online, my email was attached to the invitation to this, but I'm not really difficult to find. People think I am, but I'm really easy to find. So yeah, just email me. And if you're interested in something, when we used to do this with, multiple medical students, we used to do all the projects and do a whole list. And then we would have Dawn, who's the clerkship coordinator, would do all the projects and say, okay, who's interested in that? But that became really cumbersome because then I would get like 60 emails and only like a third of them would actually want to do anything at the end of it. So I'd rather have it to be like this, a little more, I guess, smaller, and just email me basically is the best way to do it.
Yeah, if you don't know, so it's Barnett, or you can email Steve. questions online? Thank you again, Bill, for presenting this. It's fantastic. And again, we would just really encourage you to get involved in these. We will have the slide deck and then also the recording posted online as well. This reminders, this counts for your certificate in translational, clinical and translational research, which we'll be awarding at the end of the year. So if you make sure you've signed in the back so we can record attendance. And next office hours this Friday, 4 to 5, either upstairs in HEB 205.
If you don't have research questions, ideas for last minute Christmas gifts. that works too.
Yeah,
And let's give Bill a round of applause.
yeah, thank you very much. Next Lunch and Learn is in January with Margaret Hoogland, again, talking about the library science side of research and help with that practical help. So again, thank you for coming, and we'll see you either Friday or after the new year. Thank you.